today. Be wonderful to see you. It's a privilege for me to be here. As you know, at Children's Emergency, we have many patients coming from a large catchment area, including the entire province of Manitoba, as well as Northwestern Ontario and the Kivalliq region of Nunavut. One of our jobs at Children's Hospital is to be the tertiary or quaternary referral center for all of these patients, but they start somewhere, and they often start where you are. And make their way to us. So this series and this talk today is really in an attempt to foster collaboration and connection, and also really collaborate with each other to help each other in terms of having that initial care of patients and provide the best possible outcomes. You all do an amazing job, and there's much that I and my fellow physicians can learn from you. So this will be our third session for this year, as mentioned, and we'll start again in September. I have no disclosures. My only potential for conflict of interest is, as Megan mentioned, I'm one of the master faculty for TRIC, and I will at the end encourage all of you to sign up for our next TRIC course, which occurs every spring. I also collaborated in the past on the multiple trauma guidelines, which was a privilege to do so with TREC to try to really get that best care. So our objectives today, in general for our series, is to understand and utilize best management practices for the assessment and management of pediatric illness and injury. For the three sections of today, we'll talk about the differences in children versus adults and risk factors for trauma and injury patterns, describe a systematic approach for pediatric trauma and management considerations, including radiologic investigations, and then review some injuries more commonly seen in children and the specific management and presentation of those injuries, as well as using TREC resources. So these objectives are extremely broad and nothing that we can do in even 1 hour, but we'll try to do our very best. And I just want to acknowledge and give credit to Suzanne Bano, and I'm so glad she could be here today. I have used a few of her slides and some information as well from her past trauma talks. Sue's a PEM physician at Sick Kids and the medical director of the trauma program there, as well as the chair of the Injury Prevention Committee at the Canadian Pediatric Society. So we will carry on and do the best we can in this last hour. Feel free to ask questions along the way. So let's begin with some references. Today we'll do TREC as our main reference that pulls in so many other references. So this is the newly revised TREC pediatric trauma algorithm, and we'll walk through some highlights. Of course, you can't read this slide unless your eyes are better than mine, but we will go through the red section, which is the section on the primary survey in more detail. And besides the algorithm, as usual, TREC provides the BLR, or the bottom line recommendations, as well as other resources. And these are all easily available on the TREC website. So let's start with some background. We know that kids are different. Why does this make a difference in trauma? They truly are not just little adults. And even within pediatrics, there are some major differences between infants, preschoolers, elementary age, and middle school and adolescents as well. Some of those specific differences pertain to anatomy and physiology, pharmacology, and of course, developmental and behavior. So we'll go head to toe. Overall, our patients tend to be smaller sized. This small size means that there's kind of a greater distribution of injury. Less force can actually cause more trauma. They also have a large head size. We affectionately refer to them sometimes as bobbleheads because their head is so much larger in proportion to their body, especially the young ones. The C-spine fulcrum is also higher. It's at C1 to 3 versus C6 to 7 in the adult spine, which means when they have C-spine injuries, they're often higher C-spine injuries and therefore more catastrophic. And not uncommonly, we see internal decapitation from injuries as well. The spine is very pliable ligaments, and we'll discuss that more in a few minutes. But this means that there can be cord injury without bony injury, and lesions can actually evolve over time. We call it SCORA in children. This is the term that's developed before wide use of MRI, which basically says spinal cord injury without radiographic abnormality. Now, with more MRI use, we do often see this and proceed to MRI, even if the CT is negative, if we have concerns. The airway is also more narrow, more anterior, more pliable. The torso is smaller and less protective. The ribs are more pliable. Mediastinal structures are also less fixed. So there's increased potential damage to the mediastinal structures, such as the great vessels. The diaphragm is more horizontal. This means several things. One is that the diaphragm pushes the liver and spleen down a little further and it's less protected in the abdominal cavity. This also means that the diaphragm is not as effective at expanding the lungs on inspiration, which can have implications for ventilation. The lower ribs, as mentioned, are less protective of the spleen and liver. The abdominal wall is thinner. There's decreased intra-abdominal adiposity, and the viscera are larger and more mobile. So this all increases the risk to those intra-abdominal organs. Bony pelvis is more shallow. The pelvis itself, bladder is considered an intra-abdominal organ in infants because the pelvis is so shallow. And all of this, of course, increases that risk and also leads to one injury pattern from seatbelt injuries, which can occur from improper position in car seats. Here's one of the slides from Sue with a great example related to cervical spine injury. That patient age really affects that location. The x-axis is age in years, and the y-axis is relative frequency of the injury. And you can see that the frequency of axial injuries peaks around age 3, which is the red circle on the slide, and then markedly decreases between the ages of 8 and 10. And then subaxial or lower C-spine injuries increase around the age of 8 to 10, which is that crossover point in the middle of the slide. Really, this part of the reasons that this occurs is that as the cervical spine matures, it's usually by adult anatomy, looks like adult anatomy by the age of around 8 or 10. So we know that injuries are usually occurring more in the upper cervical spine. And what we also know is that on tests that the vertebral column can actually stretch in young patients as much as 2 inches without fractures. But the spinal cord can only stretch about a 1/4 inch. And so this is where you have those spinal cord injuries. Oh, I have an arrow for the crossover point. There you go. So what about physiology? So kids have a greater blood volume in proportion to their weight. They have a decreased number of type 1 respiratory fibers with increased fatigue in addition to some of the other risk factors. They also have a higher metabolic rate, so greater vulnerability to develop hypoxemia and hypothermia. They have increased glucose requirements and decreased reserve. They compensate better until they crash. And we say adults dwindle, but kids fall off the cliff. And for those of you who were present at my DKA talk a few months ago, I told you you'd see this slide again because it makes its way into almost every presentation. And when we teach those residents, one of their favorite analogies in pediatrics is adults dwindle and children really do fall off the cliff. They compensate reasonably well until they don't. And it's important to monitor for subtle changes and know that urgent treatment, when you see those subtle changes, can make a big difference. What are the differences with respect to pharmacology? So medications and fluids are weight-based. Most medications are per kilogram with, of course, a maximum dose for most of them. You can have paradoxical reactions. They work differently in kids in some cases. We no longer use codeine, by the way, in children. So pain control can often be more challenging. And of course, with pediatrics, there's great variety in terms of developmental levels, and that can occur even within the same age group and can make assessment difficult. Communication can be challenging in both directions, both the patient to us and us to the patient. And the patient's ability to understand and accept what needs to be done varies greatly, although that might not be that different from adults, but we certainly see that in children. And then children are often quite fearful, and that can make assessments more challenging. However, children do have some advantages over adults when it comes to trauma. And one good example is the spleen. The spleen actually is a thicker capsule in children. The parenchyma is actually tougher. And interestingly enough, the vascular arrangement in the spleen changes over a lifespan. It's more transverse in children, which means a splenic injury can often injure the spleen without actually rupturing a major blood vessel. Children can also self-regulate their intraparenchymal vasculature. So there are some advantages. Children in general have less pre-existing disease, less wear and tear, less atherosclerosis, for example. And because they are generally healthy, they in some cases can have more physiologic reserve in some respects, although less in others. So let's move to the primary survey. So children and their ABCs, what to do in what order. So for this, I'd like to focus on what is different in children. Most, if not all of you see adults in trauma and have a protocol for how you approach that. So we'll skip some of the basic information, even with the information that's mostly the same in adults. We're also not going to discuss penetrating trauma today, since that is more uncommon in children and is worthy of its own talk. We all know the mnemonic, the ABCs, D, E, F, G. Maybe the F and the G are new to you, so we'll review those in more detail. So I see a question in the chat about why the change with codeine, which is a great question. What we know is codeine is metabolized in the body to kind of the active drug. And we've learned over time, sometimes the hard way, that there are rapid metabolizers of codeine and slow metabolizers of codeine. So what that means is that in some patients, you actually will get inadequate pain control. And more concerning, in other patients, you can actually have an overdose if they metabolize that too quickly. And there's been cases of young infants, especially, having fatal overdoses because of exposure to codeine in the mother. So we've removed codeine, probably, I'm not sure if across the country, but certainly in many formularies of the children's hospitals, we've removed codeine from the formulary. We do have other options, and it's important, of course, to manage pain in a very scared child who is injured. So thanks for that question. So let me ask you another question for the chat. We're going to add 2 more letters to our ABCs unique to trauma. So before you start your ABCs, you have to think about another C, and that stands for catastrophic hemorrhage. And after you do your ABCs, you need to think about S. So what does S stand for? Does anyone know? You can put that in the chat if you do. I don't see anyone. So I'll tell you, it's trauma unique to trauma. It's suspicion of injury based on mechanism. Again, unique to trauma, but also important in pediatrics as well. So at this point, we're going to go through the steps in the TREC algorithm. Again, recognizing that you may not be able to read everything from the algorithm on each slide because the letters get smaller and smaller, but I promise you that it's easily accessible online to everyone. So we need to start by assessing for obvious external hemorrhage. Apply direct pressure, a compression bandage if possible, or if needed, apply a tourniquet or a tourniquet, as you call it in Canada, for extremity bleeding. And make sure to note what time this was applied, because that's important information for subsequent care providers. Ultimately, this is all about source control, kind of stopping the bleed or stop the bleed. And I'm referring to the American College of Surgeons. They actually have an educational model called Stop the Bleed, which is also designed for lay rescuers. And it's worth a review if you're not familiar with it. A for airway. Important, of course, to position the airway, assess patency, assess the level of consciousness with kind of a rapid AVPU scale. We'll talk about that later in order to establish if we need to protect the airway secondary to a decreased level of consciousness. Always important to use spinal motion restriction when indicated, using a jaw thrust to open the airway, oral suction, oropharyngeal airway if indicated. We generally avoid nasopharyngeal airways in trauma patients because of the risk of internal skull fracture and not knowing what is behind there. We need to ensure the neck is exposed to assess for injury and tracheal deviation. And then, early intubation with manual inline stabilization, using that if the C-spine is not cleared. In pediatrics, though, it's important to remember that the pediatric airway is by definition challenging. Again, they have a larger head, they have a shorter neck, they have a tendency to fall into that flexed position and obstruct their airway. The trachea is more narrow, the tongue is larger and more rostral, which can make visualization of the vocal cords challenging. The epiglottis is longer larger, less flexible, and more acutely angled, which also can make visualization more difficult. The larynx is higher, C3, C4 versus adults at the C4, C5. And it's also conical, so it's narrowest at the cricoid cartilage. And this is not a specific airway talk, but I just wanted to show these two diagrams that may be still helpful and illustrative. On the left is a reminder of the cone-shaped airway in infants, and then on the right is that bend in the airway at the cricoid cartilage, needing that increased angle of entry. All of these make things more challenging. B, of course, is for breathing. According to the Trek guidelines, and with which I agree, looking for apnea, poor respiratory effort, signs of tension pneumothorax, such as tracheal deviation, jugular venous distension, or shifted heart sounds. Although I always say good luck in seeing JVD in small children who don't really have necks, but presumably they can have venous distension as well. And tracheal deviation, of course, is part of that important primary survey. Looking for evidence of an open pneumothorax or a sucking chest wound. Bagging with a BM if needed, to prepare for drug-assisted intubation if needed, using POCUS to look for a pericardial tamponade, hemothorax, pneumothorax. If you do see a tension pneumothorax, needle or finger thoracostomy, followed by a chest tube, and then placing occlusive dressings on any open chest wounds. Important to remember those pediatric specific issues. Kids have decreased tone at baseline, so they're quicker to increase work of breathing. They have increased airway compliance, less cartilaginous support, and so they have decreased ability to generate that negative inspiratory force. And in general, less reserved to tolerate pneumothorax and hemothorax. So with that, I'll throw in here our first case. So for our cases, I'll have you just enter your thoughts in the chat. I don't have any official polls today, but I would love to hear your thoughts in the chat. And this first case is actually a real case, which I had a number of years ago. This was an 8-year-old patient who was hit by a car backing out of the neighbor's driveway. So she was hit by the car, got up, walked home. She was brought into an outside hospital here in Winnipeg, did a great job taking care of her, did lab studies which were normal, had a chest x-ray that looked like this, just a little patchy infiltrate, and appropriately transferred her to Children's for further evaluation. So I walk in at the start of a shift. Our ED is in chaos, more chaos than usual, super busy, sick kids in recess, and this child was in the treatment room. I walk in and I find her on 15 liters non-rebreather, which is not the issue. It's a good idea to have some extra oxygen in the trauma situation. The problem was that her SAT was 88% on 15 liters. And then I look at this x-ray. What is going on? Any ideas in the chat? Okay, I see some answers. So pulmonary contusion. There may be a little pneumothorax on this particular x-ray. There wasn't, this is not actually her x-ray. This is one that I pulled from the internet to secondary to privacy concerns. But pulmonary contusion is really the concern. So when you look at this x-ray, it doesn't look super bad, but this x-ray was of course done at the other center. So what happens next? I brought her immediately to resus. We intubated, did a chest x-ray after intubation, medium-sized hemothorax, placed a chest tube, and she did actually quite well with non-operative management. So you can see the fairly rapid progression from a relatively small to a quite large lung contusion. So being aware of that possibility. So pulmonary contusions, most common injury following blunt trauma. Varies in severity. There can be small ones that don't progress or small ones that do progress for sure. This is from parenchymal shearing and bursting of the blood vessels, alveolar hemorrhage, stiffness, interstitial edema. And important to note that at least half of patients with pulmonary contusions will have no evidence of chest wall trauma. So we see hemorrhage, we see edema, we see consolidation, leads to VQ mismatch, hypoventilation, hypoxia, and can actually lead to pneumonia after a few days. The initial chest x-ray is often subtle. It progresses over 4 to 6 hours and even 24 to 48 hours. And it often blossoms after fluid. So your fluid resuscitating patients who are maybe on the drier side, then you can see the pulmonary contusion and hemorrhage actually worsen. And even up to a third of them will have a normal chest x-ray. So if you see a pulmonary contusion on CT that you don't see on chest x-ray, those are not as worrisome. That's also, by the way, true for a pneumothorax that you find on a CT that's not seen on the chest x-ray. Probably okay, no need for urgent intervention. For pulmonary contusions, management is supportive care, observation, analgesia, and supportive care can be a whole variety of care. It can be a little oxygen and observation, and it can require intubation and possibly a chest tube if they develop a hemothorax. Or respiratory failure, and being careful with fluid resuscitation as well, aggressive pulmonary toilet to try to prevent pneumonia. If you see a rib fracture, always suspect pulmonary contusion because you need pretty severe force to sustain a rib fracture. Also of note, if you see a rib fracture in your lower rib, so like the 10th to 12th rib, always think liver, spleen, kidney issues as well, again, because that significant force is required. Okay, let's move to C. So C is looking for signs of hemorrhagic shock. Keep in mind that hypotension in children reflects decompensated shock and really suggests an adequate resuscitation and a poor prognosis, right? So signs of compensated shock in children, cool skin, cap refill that's delayed, etc. Kids compensate well until they don't, right? Applying a pelvic binder if hemodynamically unstable or possible pelvic fracture. If there's compensated shock, okay to give crystalloid as your first bolus and move to Paxils early, or you can move, or we suggest moving straight to Paxils if there's active bleeding or hypotension reflecting decompensated shock. Consider tranexamic acid. We'll touch on this in a few slides, and then performing an EFAST if you have the equipment and skills. I see a question in the chat about why an occlusive dressing in open chest wounds. Couldn't there be an underlying lung injury spilling air into the pleural space? If you're absolutely right. You could be converting it to a tension pneumothorax. And when we think about a occlusive dressing on open wounds, we actually usually leave one side open for that exact reason. So it's because of occluding it on 3 sides. Thanks for that question. And then to review some pediatric specific considerations when it comes to circulation. In kids, vital signs are actually quite vital. Cardiac output is mainly heart rate dependent. Kids have a fixed stroke volume. Their heart isn't that big. And they're much more heart rate dependent than adults. So beware of persistent tachycardia, which reflects increasing compensation, but there is a limit to that. A decrease in blood pressure is an ominous sign. And a helpful decision tool is what's called the SEPA, or the Shock Index Pediatric Adjusted. This is also used in adults, the Shock Index, not the pediatric adjusted part, but it's basically heart rate over systolic blood pressure. And this is actually better than age-adjusted hypotension when you're using that as a marker in children to assess the shock status. That number greater than 0.9, which is the same as adults, we use for adolescents. And the younger you are, the number goes up. 6 to 12-year-olds greater than 1, and 4 to 6-year-olds greater than 1.2. Again, in children, early hemorrhagic shock is difficult to diagnose because of compensation. And the amount of blood loss is often underestimated. While the blood volume is actually more per kilo. So for example, infants have about 105 mils per kilo of blood, whereas adults have 70 per kilo. They're also much smaller in kilos. So small volumes can actually be a very large percentage of the total blood volume. Important to examine for hidden blood loss. Abdomen, pelvis, long bones, especially the femur, subgaleal hemorrhages, and subgaleal bleeding can actually be life-threatening in infants. D for disability. For evidence of a severe head injury, including a GCS of 8 or less or only responsive to pain, we do consider intubation. Again, most of you have heard the cliche, GCS of 8, intubate. And certainly if it's not improving or declining, we would intubate for airway protection. Important to contact neurosurgery right away in this situation, monitor for and manage potential increases in intracranial pressure, place patient in reverse Trendelenburg, head midline to maximize venous drainage, loosen the cervical collar a little bit, not too much, and then consider drug-assisted intubation with, of course, manual inline stabilization. And in children, we're very quick to treat seizures or even consider seizure prophylaxis. And of course, we need to ensure that cerebral perfusion pressure by optimizing the mean arterial pressure. If you have impending herniation, we recommend hypertonic saline at 5 mils per kilo, can be followed by mannitol and a normal saline bolus if needed. If there's evidence of neurogenic shock, such as decreases in both heart rate and blood pressure, abnormal tone, decreased strength, then we recommend starting norepi, usually at 0.1, or you can start at 0.05 and kind of increase as needed. And then you can add epi if you need as well. I often do a POCUS eval for heart function, which lets me know when I need to add epi and if that would be helpful. Some special considerations for pediatrics. As we mentioned before, varying developmental levels, which makes the history difficult. It's also more difficult to assess for level of consciousness. We do have different scoring for the Glasgow Coma score for the youngest children, but in general, in the midst of a resuscitation scenario, we usually use AVPU. And usually that's sufficient. And most of us know this scale, but just to remember, A is for alert, V responsive to voice, P responsive to pain or unresponsive. And this correlates reasonably well with the GCS. For backboards, of course, trying to minimize further injury from the board itself, which is quite an issue with children as it is adults. We really want to use that only for extrication. We take children off the backboard almost immediately when they come to the department, unless we need to take them to CT, and then we use that as a transfer device. Important because of kids' large heads, especially the small ones, when they're on a flat board, if the flat board does not have a shallow cutout for the head, important to elevate the thorax for infants and toddlers to try to keep that C-spine in line. And important to avoid spinal motion restriction if at all possible. And it's not always needed to put SMR in place just because the child cannot verbalize that their spine doesn't hurt. And so keeping that in mind. E, of course, exposure and environment. Log roll with spinal precautions to more fully evaluate the back for injury and signs of bleeding. And then with the environment, important to remember in pediatrics that they are an increased risk for hypothermia. A small body mass with a large surface area results in increased heat loss. Our goal is to maintain normothermia, documenting the temperature as we go along. And this can include a number of things, kind of warming blankets, such as the bear hugger, warmed IV fluids, and overhead heaters, which we have in our emergency for these small children. F stands for FAST, which is, you probably guessed. But in pediatrics, F stands for family, right? And it's important to involve the family as able. We know from literature and from experience that family presence in the trauma room, along with a support liaison, can make a huge difference in resuscitations, not just trauma, but other resuscitations as well. Certainly helpful to have family there for interview and history of what happened, especially with patients who can't talk or level of consciousness is decreased. Also important to update with status and plan. And here we have someone designated as a liaison, social work if they're available, otherwise another nurse to be that liaison to transmit information back and forth. If you have equipment and training available for FAST, go ahead and do that. It's another piece of information. I will say that FAST is not as well established in the younger population. It has a bit of lower sensitivity, and ultimately a true positive exam rarely directs management in children. If the FAST is positive, definitely call surgery, consider a CT scan. If the FAST is negative, there can be a number of FAST negatives. You still need clinical correlation, as with everything. Approximately a third of children with intra-abdominal injury do not actually develop free intraperitoneal fluid, and about 10% will have physiologic fluid that is mistaken as pathologic. So again, the importance of clinical correlation. So the presence of free fluid in the abdomen on FAST for children does not mandate laparotomy. And the absence of free fluid doesn't rule out significant hemorrhage. And of course, it doesn't capture easily retroperitoneal hemorrhage. So we do FAST, but it's an adjunct to our care, not a mandatory requirement. And probably is more useful in adolescents who are adult size and shape. That being said, EFAST can be helpful. So if you can get a look at those lungs to assess, hemopneumothorax and hemopericardium, can provide good information. Okay, here's my next question. We talked about A, B, C, D, E, F. What does G stand for? You can put it in the chat if you know. Glucose. Excellent. Yes. And a hint would be don't ever forget the glucose. Okay, so the higher metabolic rate in children leads to increased glucose and oxygen demands. We spoke about that already. So while this is not something generally high on the list of concerns in an adult resuscitation, although important, but adults have more reserve, and it's highly important in small children, especially the young ones in their rapid growth phase. So checking the glucose and addressing that as needed. I didn't have a slide, another slide on S, but we'll talk about that later. Suspicion of injury based on the mechanism. One slide on the secondary survey, kind of going head to toe. You're familiar with this, but for pediatric specific considerations, we use a selective finger and tube in every orifice. We don't automatically do a DRE with children unless it's absolutely indicated. A number of false negatives. There are some indications for DREs, suspected spinal cord injury to assess tone, penetrating abdominal or perineal trauma, and then pelvic injuries, including if you see blood at the urethral meatus. And the DREs rarely change management in children. And then, of course, your secondary survey will include that ample history. Allergies, medications, past history, last meal, and then events leading up to an injury. So a question in the chat, and actually that's perfect timing because my next slide is just a pause to see if there were any questions. Would you consider a certain level of hypothermia in severe head trauma brain injury? Great question. There have been many studies looking at cooling, head cooling in trauma. And I'll defer to Sue for for more knowledge of the literature. My understanding is that head cooling has been shown more effective in the setting of HIE, really in the neonatal period, but not as helpful in the context of a trauma situation or even a non-trauma resuscitative situation. The focus really is just on maximizing that cerebral perfusion pressure in order to try to preserve brain tissue. Sue, I don't know if you have any other thoughts on that.
Yeah, just coming off the, oh, sorry, there I am. No, you said that very, very well. The evidence, like you said, even there was a Cool Kids trial that was stopped halfway through because it didn't show any difference at all. And hypothermia is not indicated for traumatic brain injury at this point. I think that in tier 3 therapies, like once you're in the ICU, there's maybe more of a role for it that's being explored, but certainly not in our trauma rooms, no.
Thanks. Okay, any other questions before we move on? Okay, great. We'll have time at the end. For sure. Okay, so I wanted to talk about some general management principles unique to pediatrics. So again, we talked about S, right? The high index of suspicion based on mechanism. Really, that the chest and the abdomen are considered the same entity in a child. So an injury to one area should make you concerned about an injury to the other area as well. That being said, decision-making is really based on clinical status and hemodynamics, not imaging result. Solid organ blunt injuries in children are non-operative, about 95%, which, by the way, also is a reason that the fast scan is maybe not as helpful in pediatrics, because even if you see evidence of injury, you still might not do anything about it other than observation. And you'll do something about it. You just won't take them to the OR in that case. Generally, with solid organ blunt injuries, even with higher grade splenic and liver lax, if they're hemodynamically stable, recommend bed rest and slow return to activities. And often the first 24 to 48 hours of bed rest and observation occur in the hospital. So what about TXA in kids? Most literature actually shows no great efficacy in children, but we're missing a lot of literature in this area. I will mention that for adolescents in general, apply the adult criteria and manage them as adults if they're post-pubertal in development. We do know that TXA is reasonably safe. It's part of many protocols, but not yet quite the standard of care. And that's for a number of reasons. So the mechanism of coagulopathy is different in children versus adults. So there may not be as great of an effect, but in general, it's safe. It doesn't do any harm. It's a low cost. The utility is unclear, but we do need more studies to help support some guidelines on the use in pediatric trauma. We do know that in the adult world, TXA given within 3 hours from injury is associated with improved outcomes. And so generally we do recommend, if you know that there's active bleeding, either visible on the outside or intra-abdominal or pelvic bleeding, we do recommend a bolus dose and an infusion just to see what helps, right? Pulling everything out from the kitchen sink to try to get that done. A few more management principles. So permissive hypotension. So this approach is really a trade-off, right? You have a trade-off between the adequacy of tissue perfusion versus kind of normalizing coagulopathy and gaining hemostasis. There are well-documented complications from excessive crystalloid and some good animal studies and adult clinical trials that permissive hypotension can be helpful, but that literature is quite sparse in children. What we know is that there's increased morbidity if there's associated traumatic brain injury, which is more likely in children. And resuscitation should really be physiology driven, kind of titrating to a palpable pulse and cerebration than numbers more than anything else. The best approach is a quick move to blood products after that first 20 per kilo bolus of crystalloid, or moving quickly to packed cells, as we mentioned before. Important to think about balanced transfusion, pediatric specific massive hemorrhage protocol if you have one. If you don't have one, start thinking about plasma and platelets if you can after giving 2 transfusions of packed cells. While it might be reasonable to have a more restrictive fluid approach until bleeding is controlled, again, keeping in mind that hypotension in children it indicates a decompensated shock state. And most of these studies in permissive hypotension have been evaluated in patients with penetrating injury. So in other words, nuanced control of bleeding in children. Finally, vasopressors, the literature does show increased mortality in using that in hemorrhagic shock. So we indicate that there is a need for vasopressors such as norepi or phenylephrine if neurogenic shock, otherwise no. Not right now. Finally, important to not forget pain control, fentanyl, ketamine, morphine. Sometimes we'll give oral medications like Tylenol and Advil by rectum. To try to help with some consistent pain control. Splinting long bone fractures can assist with pain control greatly. Open fracture management, again, not forgetting the tetanus, antibiotic prophylaxis. And then optimizing that hemodynamic status before intubation. These patients are often in a catecholamine depleted state. Ketamine is a great choice for intubation. Even with head trauma, we used to avoid that in head trauma, but it does preserve hemodynamic status. And so if you're worried about that, ketamine is a good choice, as well as etomidate and others. Quick slide on imaging. We generally get a chest x-ray in all patients with moderate to severe trauma mechanism. You may be familiar with the ALARA principle, stands for as low as reasonably achievable. It really means that we image selectively. And in part, or in the most major part, is that because kids have much more time to have something turn into malignancy. And so radiation exposure at a young age, they have many more years for that to cause issues down the road. So we don't do a goldogram in pediatrics. And for those of you outside of HSC, our trauma surgery team is Gold Surgery. And so the combination of head, C-spine, chest, abdomen, pelvis CT is referred to as a goldogram. Pretty low threshold in adults for getting a goldogram, much higher threshold in kids. And we tend to target our CT imaging selectively, again, as needed. There are some rules to help guide us. For example, there's a rule about obtaining a chest CT, thoracic CT, only if you see a chest x-ray with a wide and mediastinum, or if there are findings on the chest x-ray with a vehicle-related mechanism. So using those rules can significantly decrease our use of CT scans. Some pitfalls in kids. Easy loss of airway, right? Remember the short necks and small tubes. Important to maintain that established airway. Watch your fluids. You usually haven't given enough. Follow the clinical status. A quick move to blood instead of giving more and more crystalloid. Beware of hypothermia. Beware of unusual bleeding sites. Also beware of the distended stomach. So if you've intubated, and even if not, kind of putting in an early orogastric tube. I have NG written there, but that would you'd only put in an NG if you were convinced that there wasn't any facial injuries or basilar skull fracture. As I mentioned, the diaphragm in children is the primary muscle used for ventilation. So decompressing the stomach is a high priority and can assist with ventilation. Okay, so last slide before we move to our cases. So what about injury patterns? I mentioned that at the beginning. So in kids, you are more likely to see internal injuries without obvious external signs. And as we mentioned previously, organs are less protected, they're not as fixed, so there's that increased risk of pneumothorax, hemothorax, and et cetera. But we do see symptom constellations. One particular one is the pedestrian versus motor vehicle. So a child gets hit by a motor vehicle. It really depends on where the vehicle hits, the vehicle's bumper, how tall the child is. We talk about something called Waddell's triad, which is a combination of head injury, liver spleen injury, and femur fracture when pedestrians are struck. And the head injury is often from getting struck and either falling to the ground or coming over the hood and hitting the windshield. Lap belt injuries, that triad is considered abdominal wall ecchymosis, usually a lap belt pattern, intra-abdominal injuries, and what's called the chance fracture. We'll talk about that in a second. Penetrating chest trauma, of course, is more common in adolescents and rare in young children, at least in Canada. I trained in Baltimore and we saw, unfortunately, way too much penetrating chest trauma in children for other reasons, but important to recognize that when it exists. And really the most important injury, the most frequently observed injuries in children, we mentioned pulmonary contusions with or without rib fractures, and then injuries to the tracheobronchial tree, heart, aorta, and esophagus and diaphragm are actually less rare. Are more rare, more uncommon than pulmonary contusions and rib fractures and others. However, what I should mention, let me go back to that slide just for a second. I should mention that when we do see injuries to the tracheobronchial tree, heart, aorta, et cetera, it means that there's pretty significant force involved, and that these injuries had really the highest case fatality rate. Overall, chest trauma in pediatrics has an up to 12% mortality rate in isolation and a 40% mortality rate when associated with other injuries, which it often is. Okay. So final section of our talk, we've got some cases to talk about, which illustrate some common injuries that we see. So we'll start with case 2. So this is a 7-year-old young man in the backseat of a car, seat belted, high-speed frontal collision, comes in hypovolemic shock, and abdomen is rigid. What is going on here? You can shout out or enter in the chat. Yeah, definitely concern for abdominal trauma. And you see that nice line just below the umbilicus. So that is your seatbelt sign, absolutely. So we mentioned before the seatbelt triad with abdominal wall ecchymosis, intra-abdominal injury, which is often a perforated hollow viscus, then a chance fracture. And this is a diagram of what happens with a chance fracture. Because kids will often either slip the shoulder belt behind them or it's uncomfortable, they complain, the parents put the shoulder belt behind. If they're not in a booster seat, and if it doesn't sit properly, they actually have a significant flexion distraction injury to that lumbar spine, as illustrated in the diagram there. The abdomen is less protected. I've mentioned that a few times, but so important to do that. The AP diameter is a lot smaller, so there's actually increased force between the anterior abdomen and the spinal column. So even in a well-looking child, very important to evaluate and work up for the seatbelt sign, which increases the risk of intra-abdominal injury by 30%, especially if they're tender. What are the risk factors? Shoulder belt slips or is removed. You can have some neck injury sometimes from the shoulder belt too high as well. They're mostly soft tissue, but that's a very real concern that parents quote. The slouch factor, and any of you who are parents know that kids like to slouch and kind of get comfortable in their seatbelt, which means that the lap belt can sometimes creep above the iliac spines. And that higher body center, again, increases that flexion, the risk of flexion extension. Important to observe these patients carefully, serial exams, trauma labs. If the abdomen is tender, important to think about a CT scan. And again, that booster seat purpose is to have the belts positioned properly. By simply placing that patient on the booster seat, you now have that lap belt over the iliac crest, and you have the shoulder belt over the sternum, which is where it should be. Height is more important than weight when it comes to needing a booster seat. So real quick question, does anyone know the height and age requirements for Manitoba to be able to be out of your booster seat? So you should have a booster seat. You need a booster seat by law until you reach a certain height and age. Yeah, we recommend until 12 to be. The law says 8 years, but it's actually as long as you possibly can, to be honest. And the height requirement is 4'9". We know that some 8-year-olds are shorter, and there has to be a little bit of a reasonable balance. But 4'9" is what we think that you no longer need that booster seat to position. Ultimately, I think one of my children was out of a booster at age 8. The other was in a booster until age 10 because they're different heights. And it really is looking at the seatbelt, looking how it fits, putting that booster seat in until you really have the belts where they're supposed to be. Exactly, until they can sit with a seatbelt at the proper fitting. That's actually much more important. So, great, thanks. So we talked about observation, again, serial exams, and think about a CT if you need. Okay, on the home stretch here, just a few more cases. Case 3, so you have a 3-year-old girl who falls from a second-story window. She arrives with a GCS of 12, but then quickly becomes obtunded. GCS declines to 6. The left pupil was initially reactive and is now dilated. So significant concerns for traumatic brain injury. So the goal here is to quickly identify lesions requiring emergent surgical intervention and avoiding secondary brain injury, again, controlling the ICP and supporting CPP. Management for this, again, head of bed at 30 degrees, and we do recommend reverse Trendelenburg, not just the head of bed in trauma, unless the C-spine has been cleared, or the lower spine as well. Head midline, loosened cervical collar, RSI if needed, aiming for that end tidal CO2 between 35 and 40. We no longer recommend hyperventilation routinely to manage ICP. We do recommend hyperventilation in a very specific scenario. So if a patient in front of you is acutely herniating, pupils blown, we do recommend urgent hyperventilation just until the pupil size decreases, but then no more, knowing that for many reasons, persistent hyperventilation can cause other problems. Maintain normal systolic blood pressure and euvolemia, have a plan for analgesia and sedation to prevent pain and agitation, treating seizures aggressively. The other thing, analgesia and sedation can help mitigate some increased muscular activity, which actually may contribute to increased ICP. Osmolar agents, we recommend hypertonic saline first. There's a slight preference for that. Mannitol works more quickly, but then of course you have that anticipated osmotic diuresis. And if there's hemodynamic instability where you're worried about your fluids, then hypertonic saline is better. And then considerations in children, again, that higher metabolic rate, need for glucose, and then considering if you need anti-epileptic medications. A quick review of Nexus criteria used in adults. So the 5 low-risk criteria are no posterior midline tenderness, normal level of alertness, and no focal neurologic deficit, no painful distracting injuries, and no intoxication. So in adults, if a patient meets all the criteria, you don't need C-spine x-ray, and the negative predictive value is about 99.8%, which is pretty good. The rule has been validated in older children, but it's potentially less helpful at younger ages. Again, around age 8 is when the C-spine becomes adult-like. So there is some evidence that the rule can be used in children 2 years and older, but definitely not validated in children under the age of 2 years. And I'll mention that there's also a Canadian C-spine rule, which can be used in adults, but that's not validated for patients less than 16 years. So we don't use that. This is a slide from Sue about a great model developed by PCARN a number of years ago to talk about, when do we not have to do C-spine imaging, and really highlighted 8 factors that were associated with C-spine injuries, including the altered mental status, focal neuro-defect or deficit, neck pain, torticollis, substantial torso injury, predisposing condition, such as trisomy 21, diving, injury, and a high-risk motor vehicle collision. So those are some other factors to consider. Okay, so when to CT and more minor head injuries, we'll save that for another time because it's a good discussion around the PCARN and CATCH rules, and we'll also talk about concussion management, but that is not for today. And any talk on pediatric trauma, especially head trauma, it's important just to mention an unfortunately common presentation in infants, abusive head trauma, called formerly shaken baby syndrome, where shaking babies can lead to subdural hematomas by tearing of the bridging veins, also leads to retinal hemorrhages, and can have significant neurologic sequelae or death. The management, however, is similar to that of other patients with head trauma. The associated injuries might be different, but the management is essentially the same. And even though small infants do have an open fontanelle, it only mitigates the increased intracranial pressure for a short while. Okay. Case 4. 10-year-old boy, head-on collision playing football, comes in with neck pain, paresthesias, tingling of the lower extremities. What in my day in high school, the football coach would call these stingers. And as soon as the tingling went away, they went back in the game. We don't do that anymore, thank goodness. In this particular case, x-rays and CT was normal. And what is going on? It's, the positive radiology sign with the red circle on this particular slide. But this is SCIWORA, right? Spinal cord injury without radiographic abnormality, assuming you don't yet have an MRI. And it's due to that stretching of the elastic ligaments and stretching of the cords. And I will mention that this is most common in hyperflexion injuries, but can also occur with direct axial load. And again, those of you who have parents or work with kids, you recognize that we now keep car seats facing backwards longer and longer. Even if kids have their legs kind of all scrunched up, we keep them backwards because it reduces the risk of spinal cord injury. Again, because of that flexion, the risk for flexion and extension. So keeping those children backwards for frontal collisions makes a huge difference, right? So SCORE probably accounts for up to 70% of spinal cord injuries in children, and it's most common, as you might guess, in children less than 8 years of age. Symptoms may be immediate or delayed for a couple of days, and MRI is the way to diagnose this. And complete recovery is usually pretty likely unless the cord is transected. Two more cases. Okay, so get your fingers ready to type in the chat because I'd love to hear your opinion on this one. 11-year-old girl who's riding her bike. She hits a rock and she falls. She comes in to get checked out. Her vital signs are stable. She looks well. Abdomen's a little bit tender. And you do an exam and you see this abdomen. What is going on? Handlebar sign. Yep, exactly. You guys got that without my clue. I was going to point an arrow and do a close-up. So this is the handlebar sign or the handlebar tattoo. So we think of many things about safety on bicycles, but we must include handlebar safety. So kids fall, the handlebars are twisted, and a very focal point in part of the abdomen. And you can see in this cartoon, right, a small circular bruise can be fairly subtle unless we're looking for it. So we think of handlebars more like focused spears. A handlebar injury is 10 times more likely to cause severe intra-abdominal injury because of all the force concentrated in one small area. So most common injuries to solid organs, pancreas, liver, spleen, can have a small bowel hematoma and perforation, or even a hernia of the abdominal wall. External findings are often subtle, and management at a minimum is observation with serial exams and blood work, monitoring of vital signs, urine output, etc. And the literature suggests that up to half of children with handlebar injuries are misdiagnosed on their initial presentation. So important to have that S, suspicion of injury, based on mechanism. Okay, final case, and then we'll turn it over for questions. 2-year-old boy playing in the driveway. A car backs out of garage and hits a bump. The child is extricated, arrives via EMS. What is going on? I'll have you put that in the chat. Christo, good question. How long for observation? We generally say 24 hours. Usually if there's significant injury, you'll see that in 24 hours. And of course, serial labs to make sure that things are not going in the wrong direction. Okay. So what's going on with this young man in the photo? Scott, great. So SVC syndrome. So we do see this, fortunately infrequently, but this is traumatic asphyxia, right? So this is a thoracic crush injury with external restriction of thorax. And where we see it is when kids get stuck. They get stuck under garage doors, which happens less frequently now with safety mechanisms, elevators, revolving doors, like a vehicle versus a wall. And you might remember there was I think a Star Trek actor who a few years ago had a malfunctioning vehicle and actually died from traumatic asphyxia because the vehicle rolled back and trapped him. Vehicle tires getting run over by a vehicle. This really comes from acute inspiration and glottic closure in the setting of external pressure, increased intrathoracic and mediastinal pressure, venous congestion, etc. How it presents with this kind of craniocervical cyanosis, also known as the masque ecchymotique, which I probably mispronounced because I don't speak French, but that is that cyanosis that you get along with the SVC syndrome, as Scott mentioned. Facial edema, subconjunctival hemorrhages and petechiae, rib fractures, pulmonary contusions, solid organ injuries, neurologic sequelae. And the management, if they survive to presentation, is supportive as well as a full trauma evaluation. Okay. So many types of trauma we didn't discuss. We didn't talk about burns or electrical injuries or submersion injuries or heat and cold injuries, but there's only so much time. So quick summary tidbits. Kids are different. Be aware of differences and what they can mean. Have a high suspicion of injury patterns based on age and mechanism. Have a systematic approach to injury evaluation. Remember your C, A, B, C, D, E, F, G, S. Watch and intervene for signs of compensated shock. Selective choice of imaging. And as always, anytime, phone a friend. And finally, our trick, our high fidelity sim course, Trauma Resuscitation in Kids, was offered every spring. Feel free to reach out for more details. And then for some questions for you, I'd love to hear from you what you saw and heard today that resonated the most. And then what will you remember from today when you see your next pediatric trauma case? And I will stop there and open it up for questions.